I gave this talk last year, and it's very similar this year. So if we've got people who've come back again, I do apologise, but this is what Carlo asked me to do. Of course, I have updated it with some of the latest data, and actually from ASCO, which was only a couple of weeks ago in Chicago. And what I really like to do is start with the very basics, which is when we talk about ER-positive breast cancer, estrogen receptor-positive breast cancer, well, what is it? What is the ER? And I think that that's a really important part to aid all of our understanding. And please, trust me, I also give this kind of beginning to my talk to the registrars and to any junior doctors as well. And I take it right down because I think so many of us don't really understand that it's vitally important that we try and get somewhere. So we're going to start with what is the ER, and the picture on the left is a whole bunch of brown dots, and that is what a pathologist sees when they're scoring a tumour sample and says that is now a positive sample for the estrogen receptor. The brown dots are the nuclei of the cells. That's where your estrogen receptor sits. The diagram to the right of that is something that I wouldn't really expect anybody to understand. And so what I've done is redrawn it as a cartoon. So that's a ribbon diagram looking at the structure of the estrogen receptor with estrogen bound into it. And that is what you see with my little diagram. Okay, so you've got the receptor sitting there. The pink bit is something called helix 12. The estrogen sits in the receptor, so this is the hormone that's coming from from the ovaries in premenopausal women, coming predominantly from the fat in postmenopausal women, sits in the receiver in the nucleus, and then what happens is you get closure of that thing over the top. It opens up the yellow area, which is activation function 2. That then recruits co-activators. This is far too much information, but I hope that what I can do with the next few slides is explain how some of the treatments work. Now, if that's a cancer cell, what it does is it tells that cell to divide, to survive, and the cancer to grow. So what about tamoxifen? I think everybody in the room will have heard about tamoxifen. It was it's been around now for over 50 years. First introduced, I am now going to explain my first comment. First introduced in Manchester. Some of the first clinical trials were done by my father, who was married to Lesley, but is no longer. But as she said earlier on, she didn't divorce me. So what we have with tamoxifen is a different situation. So when tamoxifen, it still binds into the estrogen receptor, but it blocks that closure of the pink bit, so you don't get the co-activators binding. This is in the breast cancer cell, and so it's acting like an anti-estrogen. Now, we still use tamoxifen, a fair amount, predominantly in premenopausal women and predominantly in the adjuvant setting. If we look at that pathology slide, you can see that you've got brown dots before you take the tamoxifen, and you've got brown dots after you take the tamoxifen. So the receptor's still there, it's just being blocked by the tamoxifen. So what can we do about that? It's not a huge problem, but we think we can do better than the tamoxifen. And the first way that that was done was with a drug called fulvestrant or Faslodex. Many of you may be on that. I'm surprised you're still sitting down, but you'll understand why if you have had it. It looks very much like estrogen. So again, please, there is not going to be a test at the end of this about the chemical structure of steroids and estrogen, but I think you can see that obviously I've just doctored this just with a big sidearm, this blue line that I put there, lots of fluorine atoms on it, so it looks really foreign to the cell. But the backbone is estrogen, and so that binds the receptor as well, but it does it in a way that makes it look so foreign that what the body does is it gets rid of the receptor. Okay, so it degrades the receptor, and that's the kind of new class of drug. Fulvestrant has been around for a while, but there are some new kids on the block. And this is what you see with the pathology slide. After you've treated with fulvestrant, the brown dots have now really faded, so you can barely see any brown on there, and that's because the receptor has been taken out by the body in response to this drug binding. So it's called a selective estrogen receptor degrader. Fulvestrant can only be given by intramuscular injection, so those of you that have had it, you'll know that it's given into both buttocks, 5 mils of oily fluid, and that limits the dose that we can actually deliver, because in contrast to America, we've only got 2 buttocks, generally in the European Union, or even the UK as we are now. However, there are lots of tablets, oral drugs that have now come or coming onto the market, and this is a real focus of research. A lot of the drug companies have got their candidates coming through, and the first one to make it was elacestrant or Cursudu, and that was first to be licensed for use, and its license is in the after first line, or at least one prior line of endocrine therapy, for patients that did at least 12 months of that treatment, which is an interesting approval, which we could discuss. The other key part is that we need an activating ER mutation. So this is the ESR1 is the gene for the protein, which is the estrogen receptor, and a mutation in that receptor is required. So if we go back to my little diagrams, estrogen receptor mutations, ESR1 mutations, only develop during treatment. So they're a way that the cancer learns to overcome the treatment. So if you like, it's the deprivation of estrogen in particular with the treatments like letrozole, anastrozole, exemestane that many of you will have or are on. It suppresses the amount of estrogen to virtually zero in the body, but the cancer cells eventually work out a way of growing even though there's no estrogen around. And the way they do that is by, they develop these mutations that allows the receptor to signal even though there's no estrogen there. So it's called an activating mutation in the receptor. And if we bind tamoxifen in there, it doesn't do anything because the receptor's still there. It's still signaling. So the tamoxifen will do absolutely nothing. But if we put Cursudu in there, we get rid of that receptor, and therefore we still have anti-estrogenic abilities, if you like, from this drug, even though the receptor is mutated. It turns out that that elacestrant is actually better than fulvestrant. So fulvestrant should be able to do this, but for molecular reasons it can't. So elacestrant is better. And if you can just look at those figures that you've got, when we're talking about 6-month control and 1-year control, the 1-year control rates, about a quarter of patients would have their cancer controlled with elacestrant, fewer than 10% with fulvestrant. It improves survival, it's well tolerated, and the update from last year is that this is now NICE approved, and the ESR1 testing that we do, we can't do that on the primary tumor. We can't really do it on, if somebody's diagnosed, well, actually, no, we can't do it if somebody's diagnosed with metastatic disease, with secondary breast cancer, because there won't be any ESR1 mutations there. It's only after treatment. We should always be thinking about trying to get a biopsy at progression anyway, and a liquid biopsy is the way that, the best way of doing this to detect the ESR1 mutation. And circulating tumor DNA analysis is now available. The testing is, as I said, should be done at progression after first-line treatment. And the way this is going, and I couldn't not present some of the data from ASCO, which is on the SERENA-6 study that some of you may have been involved with. And there are some issues with this study, and we don't really have long enough to sort of go into this, but just over 3,000 women were screened whilst on their first-line therapy for ER-positive metastatic breast cancer, of whom about 500 were detected to have an ESR1 mutation, of whom about 300 were randomized in the trial. And the randomization was to either just carry on as they were on an aromatase inhibitor and a CDK4/6 inhibitor, or to switch the aromatase inhibitor to camizestrant. And this is AstraZeneca's oral selective estrogen receptor downregulator. Now, this got a plenary presentation at ASCO, so it's obviously an important clinical trial. And the effective result was that switching to camizestrant at molecular progression, so when you could detect one of these mutations coming through, improved the duration of first disease control. So you had approximately 16 months if you did the switch, and this is before a scan showed progression. This is just on the blood test, do the switch. That meant that you got to 16 months on average, whereas the women who had stayed on the same treatment, they only got an average of about 9 months before the cancer progressed. And so you think, well, great, this is something we should be just bringing this in straight away and should be a standard of care. But I would caution about that. The one thing that was very important was that by doing this, quality of life was maintained better. And that's, of course, a vital, absolutely vital part of the treatments that we're giving. And generally speaking, the longer we control the cancer, the better the quality of life. And so that is seen, and that's, apologies for just putting up a Kaplan-Meier plot because it's very technical, but the green line at the top, the higher the line, the better the control of quality of life. And then we've dropped down, and you can see the difference between the two lines, between the new treatment at the top and the existing treatment at the bottom. But the issue with the trial really was that when we looked at, or when the team looked at, well, what happened after progression on the standard treatment, patients generally went on to a second-line treatment, and that went actually slightly longer in average than the total duration of this experimental arm at the top. So I think the question there is, have we potentially lost out some time of disease control, and have we lost out potentially on some survival, more importantly, by switching too early? And that was a lot of the discussion that came out from the presentation of these data. I thought it important to mention it because you've highly likely seen some of it. You've seen some of the news that comes back from ASCO. And I think it's important to say that we're not there yet. We just need longer follow-up of this study to work out whether this is going to be the way forward and doing early switches in treatment based on molecular progression. So the final part of the talk, I just wanted to talk about combination therapies that are available and some that are emerging. The first thing is the cycle-independent kinase inhibitors, which we've heard a little bit about already from the audit. We think they are standard of care, so why are so few women being registered as having them? And I think, as Mark said, it's probably a recording issue. But the question that we had a couple of years ago was, well, we know that these drugs are active, but are they as active as chemotherapy in women who've got a really quite advanced disease? So maybe a lot of liver metastases or symptomatic disease with lots of disease burden. And the Right Choice study came along, and it took women who were in that situation, pre or perimenopausal women with advanced disease, something called visceral crisis or imminent visceral crisis, which Fatima has done a lot to try and help define with her ABC work, randomized to standard of care combination chemotherapy or AI and CDK4/6 inhibitor, and the result was that, if anything, it's slightly better to give the endocrine therapy. So this idea that we need to be jumping to chemotherapy for people with visceral disease, even if it's quite advanced visceral disease, is just not true. And this is a case, the CT scan that I showed you was a very young lady of mine who'd had a de novo presentation with a very advanced disease a few years ago. And after she's had several months of treatment, her extensive liver metastases responded really, really nicely to treatment, with the blood parameters similarly improving. So I think this is our standard of care, and really we do need to work out some better biomarkers to work out exactly who we shouldn't be treating this way, and maybe some people do need chemotherapy, and that I think we're not completely there yet with that, but generally speaking, the first-line treatment, in my opinion, is a combination of AI and CDK4/6. But what about other combinations? So PI3 kinase pathway is a very important pathway. It's the most commonly mutated pathway in advanced ER-positive breast cancer, and around about 50% of the population with advanced ER-positive breast cancer will have a mutation in one member of the family, of the pathway. So either PIK3CA, that's PI3 kinase itself, P10, about 5% will have a loss of P10, and about 5% will have an activating mutation in AKT itself. And there are several drugs that you may have heard of, been on, currently on, which are used to target at different levels of this pathway. Alpelisib, capivasertib, and everolimus. Now, everolimus I'm not going to talk about. It's been around for an awfully long time. Alpelisib is a nice approved second-line therapy, PI3 kinase inhibitor, given in combination with fulvestrant at the moment, and the patients must have a PIK3CA, a PI3 kinase mutation specifically. It can be tested in the primary cancer because these are what we call driver mutations. So they are one of the earliest mutations in the development of the breast cancer. So in contrast to ESR1, which is an adaptive mutation by the cancer, the PI3 kinase is a driver mutation, so it'll be there from the start. Daily tablet, about a quarter of patients discontinue due to side effects. It's given continuously. Average duration of cancer control is about 11 versus 6 months, but no convincing improvement in overall survival. So quite a toxic treatment. It does work very well for some patients, so I'm not discounting it. I'm not throwing it out at all. But the next treatment that came along this is new since last year, that's just been approved, is capivasertib. This is an AKT inhibitor. Nice verdict, as I said, was positive this year. Is also given with fulvestrant, and so of course there's an awful lot of clinical trial work going on now to think about adding these agents to the oral SERDs as well. The eligibility for capivasertib is a bit broader. So you can have a PI3 kinase mutation, activating mutation in AKT, or loss of P10. So that's a slightly more complicated testing scenario. And there are two ways now that can be done in England. One is that it can go, and actually I think Scotland haven't approved capivasertib yet. But in England, the testing can either be on the tumour tissue during first-line therapy or at diagnosis of metastatic disease, or we can do circulating tumour DNA analysis at the point of progression that will give you the ESR1 mutation as well as all of these three pathway components in the PI3 kinase pathway. Capivasertib is 4 days on, 3 days off, which is actually just because that's the way the drug works better in preclinical models. So in the early testing of this agent in the laboratory, it worked better to give it intermittently versus continuously. But I think that's also better for patients. So you have 4 days of treatment, then a drug holiday, 4 days on, 3 days off. And so I think that's a more manageable, and I think that is part of the reason why only 1 in 8 stop the treatment because of side effects. That's still a fair number, and the side effects are still an issue with capivasertib: diarrhea, rash, nausea, and some hyperglycemia, some raised blood sugar as well. Average duration of cancer control, 7 versus 3. And the survival is probably longer. The follow-up is a little bit immature still at the moment. The FDA did an analysis they presented at San Antonio and demonstrated that in patients with the mutated pathways, the survival looked very, very encouraging with this combination. So we wait for that final analysis, but it does look very encouraging. And as I've said, the testing is a little bit more complex. Can we do better? Well, very briefly, inavolisib is one agent that looks very active in women who are relapsing on their adjuvant endocrine therapy or very soon afterwards. So a really resistant population of tumors, and giving triple therapy, so adding in your PI3 kinase inhibitor to CDK4/6 inhibitor and AI seems to be, fulvestrant, it looks like a really active approach. The final slide here is just sort of one that is comparing side effect profiles, and I think that is important, but actually I think that for the majority we're looking at efficacy and improving side effects, and actually even that triple combination had fewer people stopping the treatment than with capivasertib and fulvestrant, and therefore fewer again than with alpelisib and fulvestrant. So I think tolerability is going to get better. And maybe next year there'll be some data on mutant-specific PI3 kinase inhibitors which are coming through. So there's an awful lot of research going on in ER-positive, HER2-negative breast cancer, and it very much is a case, and I know we had a lot of talk last time about identifying clinical trials and trying to get onto those clinical trials, and I fully support that. We're actually redesigning our website in the Manchester Breast Centre to put all of our clinical trials, both prevention, early and advanced, on there, so that we can try and encourage clinical trial participation and being part of this wave of research. So my summary, there are multiple new ER targeting agents coming. Defining who will benefit is going to be the key. Optimizing side effect management is clearly extremely important, and getting the point across to I've now done 10 talks to different units around the country, just half an hour to sort of update them on capivasertib and the side effects. And I think getting that message out and then getting the communication to the patients right is vital. And I think dynamic changes in blood markers such as ctDNA may prove really useful in optimizing our treatment strategies. But I think, again, we're not quite there on how we should do that when it comes to ctDNA, but hopefully next year we'll have more information. Thank you.
Thank you very much, Sacha. And you did mention the early days of tamoxifen and my slight relationship with some of that work. What I found quite interesting listening to that talk, though, was that I started working in breast cancer in the very early 80s. So that shows how old I am. And one of the things that we didn't even know at the time was why tamoxifen actually was working on some patients but not others. And I think what Sacha has revealed here is that cancer is so sneaky, basically. It finds ways round things. So I think that was a wonderful presentation. Thank you. But my question is, how on earth, and you touched on it in your summary, how on earth in a busy clinic do you actually find time to explain to patients the rationale and the logic for the treatments that you're going to offer them?
Yeah, I think pictures speak 1,000 words, and I think that if probably the thing to do is to actually try to develop some better diagrams. Yes. My consultations usually start with, when we've got into this part, start with, I didn't go to art school, but, and then I have a go at drawing some of the stuff that's on here. So quite why I haven't, well, no, you can feed back and tell me what you think of the slides and the diagrams and whether it's helpful or not. But maybe we just need to sort of put these onto some very simple one-pagers that say, well, this is the one I think you want. There's another option, some really easy to understand, as opposed to perhaps the 5, 6, 7 page information sheets that are very dry and predominantly talk about side effects because legally we're obliged to.
Can't agree more. Now, we've got a few questions here online, but do indicate if you wish somebody to come with a microphone and ask your question. Here's an interesting one for you, Sacha. If I have no hormones left in my body, i.e. I've had my overdrives out, does that mean I must have some kind of mutation, or doesn't it work like that?
I assume that was predictive texting with the overdrives. Although I do like the idea that that's what they're called. You will have, even if you've had your ovaries out, you will have hormones in your body. Estrogen is produced by the aromatase enzyme, so androgens are converted to estrogens. That happens predominantly in fat, mainly in abdominal fat, but also in other tissues. So it is not true that postmenopausal women have no estrogen. You know, in terms of levels, a premenopausal woman would usually be well above 100 picomoles. Postmenopausal women can run at around sort of 30 to 70 on average. It can be a bit higher than that, particularly with a lot of abdominal fat. And so what the drugs like aromatase inhibitors do is that they drop that down to pretty much undetectable levels. The detection limit's about 3 picomolar, and it should be pretty much below that level on an aromatase inhibitor.
Great. Now, here's an easy one for you to deal with. I think I could answer it.
Go for it.
No. The big 198 trial showed that letrozole was more effective than tamoxifen for ER-positive lobular cancer. Is this correct? And is it widely known? Should I have been given letrozole instead of tamoxifen after primary cancer as a premenopausal woman?
I don't think it is widely known. And yeah, it's so letrozole. The aromatase inhibitors do look better than tamoxifen, and this is from some of the neoadjuvant trials as well. So in patients whose tumours are a slightly lower level expressing ER, it looks like the aromatase inhibitors are better than tamoxifen, and yes, it looks like that is the case with the lobular cancers as well.
Great. So, question, yes, at the back there, the lady that is being approached with a microphone.
Thank you. It was just a question about the ESR1 mutation percentages. So on my Foundation 1 test, I had a ESR1 mutation of 6.6%. So last year, I was fortunate enough to be given elacestrant. However, it worked amazingly well for 2 tumours, but then everything else progressed. So my view and my oncologist's view was it isn't necessarily always great as a monotherapy, and there are trials which are out there at the moment suggesting that. But would you be able to explain the ESR1 percentage mutation bit, and really, if you've got extensive disease, so I have extensive bone mets and some liver mets, would you be putting somebody on it if they had a mutation of 6.6%?
Yeah. So that's actually fairly high for a variant allele frequency in the blood. We would anything above 0.1%. So you're really at very, very low levels. The difficulty is working out, and we can't work this out yet, the subclonal mutation that is then going to cause, is not going to be what we call a passenger mutation. So if you've got a passenger and you inhibit it, it's not going to have a major impact on the tumor growth. We don't yet know. We can't identify that. If you've got a positive mutation, you'll have the treatment, and hopefully it's going to control the cancer for a decent length of time. Just like every other treatment, unfortunately, the cancer will work out how to grow around that. And if it's only a couple of the metastases that have developed that ESR1 mutation, then of course you're not going to get as much bang for your buck in those other tumours. So we can't biopsy every individual tumour, and that's the potential beauty of ctDNA. What I think might come in the future, or it should come in the future, it's just when, is serial monitoring. And then you're looking to see what else is starting to come through and whether that is targetable as well. Okay, but I think we're a way off that, and the expense of doing that is huge.
Thank you. The lady in green has been gesticulating for a while, and then we'll come to the front here.
Is that, yeah. You talked about having a biopsy to test for mutations. My breast cancer tumour is very small. I found it really difficult to get a biopsy. So does a liquid, can you have a liquid biopsy instead? And what is the liquid biopsy? A
liquid biopsy just means a blood test.
Oh, right. Okay.
So thank you very much for making me say that, and I will amend the slides forthwith. So yeah, liquid biopsy, sorry, it's just a blood test. So you do the blood, look at the plasma, get the DNA out, and there's a lot of DNA in there, but we're looking for the tumour DNA, and looking for specific mutations in it. In terms of, there are a couple of issues with that. So if you've got very low burden, so that means not very many bits of metastatic breast cancer, then, and it's ER positive, then you could have that test to identify the mutations. The problem is that the lower the burden of disease, the less likely it is to be positive, so less likely we are to be able to identify the tumour DNA. And there are some cancers that don't seem to shed it into the bloodstream.
Interesting.
Yeah.
The lady in pink.
Hi.
Pretty in pink.
Thank you. What is left for people who are on their last line of treatment? I've had letrozole, exmestane, fulvestrant, and are now just on chemo. Are there any studies trials that we can join? I've done 3 trials already. I've done a trial every time, and I've got extensive bone, liver, lung mets everywhere. So what is left for me? So
we love a trial junkie.
Yeah.
And very, very difficult, and my heart absolutely goes out to you. I do not know whether there will be something available for you, for example, at the Christie. We tend in this situation to be thinking also about first in man or woman trials. So just as an example, there is a study open at the Christie at the moment with the experimental medicine team looking at CDK2 inhibitor. Now there's tight competition. Whenever these trials are open, they're generally open internationally. There's competition for slots. And so it is very much just a case of first come, first serve.
But I've been given a ballpark figure now, so I've been given a certain amount of time. But I've managed 7 years, a lot longer than they said I would do, so it's great. But I've always gone for trials, I've always gone for anything. But now there's nothing. It's like a desert out there.
Yeah, there is. Unfortunately, we get to that bit. And we are always looking for the next trial, the next encouraging drug that's coming along. And so when we're talking about palbociclib, ribociclib, and abemaciclib, they are CDK4/6 inhibitors, cyclin-dependent kinase 4/6 inhibitors. Yeah, exactly. But there are other members of the CDK family that do slightly different things within the cell and are looking encouraging. Now, whether or not they are going to be encouraging and give lots of life to somebody who's had lots of prior therapy, generally not. You generally need to find something in a totally different pathway that happens to be now upregulated in your cancer. So I'm not trying to say that this trial would be the be-all and end-all for you. It was just an example of novel agents that are coming through.
Transferred to Christie?
You're where, sorry?
Nottingham.
So if you...
I wonder if we could perhaps take that question later, because
I thought it might help other people who are in the same position.
Well, one of the important things also remember is always look at things like the Make Seconds Count website and other things, but perhaps Sacha,
the other thing to say is that we are redesigning the website in Manchester, and I think that it's then it's our duty to say what trials are available. But then you would have to communicate with or through your oncologist to say, because I think you also, there needs to be an education about whether you're eligible for that clinical trial or whether you stand a chance of being eligible for it. And if you've had 10 lines of therapy and this is a second, third line therapy trial, then the answer would be no. So it's
the voice of people who are on the last line.
Yeah.
Because I haven't heard anything about the people on the last line. That's why.
Yeah,
It is an important
yeah.
issue. I can understand
I
your
agree.
concern. So if we could have the lady in black at the front here, and then actually Liza Reardon at the back has been wanting to ask a question as well.
Yeah, from lovely pink to boring black, sorry. There were a few questions from people on the Make Seconds Count Facebook page about lobular cancer. So on behalf of them, I wanted to ask, I've got lobular cancer. Do the treatments work the same? Because I asked my oncologist, I am on the same treatment as you would for ductal cancer. Are they just treated the same? And she said yes. And I wanted to know, is there any research into lobular as a separate type of cancer with these treatments in mind? Is the efficacy looked at?
Yeah,
That was a good
it
word.
is.
For lobular.
Yeah, generally speaking, in all of the clinical trials, lobular and ductal are separated out in what we call the forest plot, which is where you're looking at subgroups, you're trying to see whether any do better or worse. Generally speaking, lobular does about the same. Is there any specific research into lobular? Absolutely. There was a trial called Rollo that was running in the UK, looking at a particular vulnerability that's been identified in lobular cells. This is a big topic of research in Manchester with Rob Clark leading it. We've now got the Lobular Moonshot programme, which is really trying to, identify those vulnerabilities and determine what extra treatments, and it is very much looking at treatment. There are other issues, things like screening as well, but very much that is a hot topic of research.
Sacha, I'm going to try and amalgamate some of the questions because we've got lots coming in online, and there are quite a few people asking about switching. And here's sort of one interesting one. I'm on alpelisib as I have a PIC mutation. I'm tolerating side effects well, but should I be asking to change to capivasertib or because they've got better survival outcomes?
So
Explain.
I think if you're tolerating the treatment, I think part of the issue with alpelisib was the number of people that had to stop the treatment. I think if you're on it, you're tolerating it well, I would not jump ship. I think if you start it and it causes all sorts of problems very early on, then I think switching at that point will be reasonable.
But you can see, and this is reflected in some of the other questions. When people come back from all the big conferences and see better survival data coming in from other drugs, you can understand why, from a patient's point of view, they think, well, why can't I switch to the better one?
Yeah, absolutely. And then you have other things like Enhertu for ER low, which even despite the better survival advantage, NICE then reject.
Thanks, yeah. Lady at the back there, and then actually if Fatima could ask a final question almost, I think.
Yeah. Hi, I was on originally palbociclib and fulvestrant when I would live down south, and then I was moved up north. When I came north, I was asked would I come off fulvestrant and go on an astrazole, which I did, not because it failed or anything, it was just I was asked would I switch. Then, obviously when the palbo failed, I asked about trials, had the PIC3 mutation and was told that I'd be eligible for that trial. But then, when I was ready to go on it, they said, oh, we've overlooked, you've had fulvestrant before, so you can't go on the trial. Mm. Does that mean now forever and a day, anything that needs fulvestrant, I can't go on a trial?
Are you talking about a trial, or are you talking about just the standard of care treatment? So we are policed quite hard on the eligibility criteria for new expensive drugs.
Yeah.
And so I think that in that situation where you stopped the fulvestrant, I would make without
It wasn't my
progression.
choice, though.
Exactly. Then I would make the case that you've not progressed on it, and therefore it would be reasonable to consider you for any of these treatments. And I think I would get that through. And where are you?
Christy.
So we can talk about it. I think that it's. I don't like these rules. I think the rules serve a purpose for not just having expensive drugs doled out all over the place when there's no evidence for them or chance of success. But I think there are certain issues that, like this, yours sounds like, that is just a bit odd, and therefore we could make the case that we can do things a bit differently.
Great, thanks. Fatima.
So just 2 comments about the switching from one treatment to the other. So please remember that there is no treatment that has 100% efficacy. So if it's working on your cancer, you should not change it, right? Yeah. Because you don't know if the new treatment is going to work on your cancer. Yeah. So if you're tolerating well and there is a response, and a response may be just the control of the tumor, keeping the tumor the same, then you should not change, because there is no way that the new treatment is going to work in 100% of the cases, right? And regarding this issue of always using fulvestrant or always using an AI for certain types of trials, this is something you need to help us, because some of us are even getting tired of saying the same thing over and over again, to say that we will not be able to run trials, compare, for example, looking into capivasertib plus aromatase inhibitor, capivasertib plus fulvestrant, capivasertib plus tamoxifen. So these drugs should be approved on any hormonal therapy plus capivasertib. And then we will choose whatever you have not taken before and combine the new drug. To do that, all we need to do is a very simple, we call it drug-drug interaction. It's a test that you do it in the lab to see if one treatment interferes with the other and reduces the efficacy of the other. But for that is a very simple test. And then they should be approved in a broader way and leave us to decide which one to compare. But the rules are not really patient-centric also.
Oh, no.
Sounds like an important topic for the next consensus conference for us to debate, I think, Fatima. Just one quick last question from the left.
I feel very fortunate. I'm 1 month into Elestrant, but I can't find any data, because I think I'm one of 3 people in my trust who are on the drug. Nobody knows how long, I've read that it's quite slow on the uptake, so 3 months I'm not going to see any difference.
Sorry, slow on the uptake.
Slow on the response. Don't expect too much of a response to tumours within 3 months.
I would say that with almost all endocrine therapies, certainly single-agent endocrine therapies, don't be looking for a response. Stability is great. As long as we've got control. I mean, Fatima was just talking about, if you've got control, don't switch treatment.
No.
Control is good, and it results in just as good survival as a partial response. Okay, so that's fine. So what we don't want to see, of course, is progression.
No.
So if the cancer's, gone up,
but I read that the CA153 markers are going up in the first. Don't look at those.
Certainly don't look at those early in treatment, because so the case that I showed of a woman with a lot of liver metastases, her CA153 was 4,000. Within 4 weeks, it had gone to 6,000. She had disease control for 3 years. So if you just looked at the CA153, you'd have thrown away 3 years of treatment and 3 years of life. So keep on it, get to your first scan. That's the important part.
And on that note, I think we better thank Sacha for his talk, and thank you.